Brittany Maynard took her last breath on November 1st, 2014. Brittany was diagnosed with a brain tumor that would end her life. She was able to die peacefully in the arms of the people she loved the most, instead of possibly going out in a morphine-resistant pain while suffering with cognitive and motor loss. Brittany was able to go out peacefully thanks to the Oregon Death and Dignity Act, which was enacted in 1997. She tried surgery, and neither radiation nor chemotherapy was an option. Her only option was to die, but it was her choice to decide how she would go out. Brittany made a brave and educated decision when she chose physician-assisted suicide. She evaluated all of her options and chose what was best for her. If I was in her shoes, I would have made the same choice. Which is exactly what physician-assisted suicide should be. Physician-assisted suicide, which is defined as physician prescription and patient consumption of medications for the sole purpose of causing death, is considered legalized in some form or fashion in 5 states, including Oregon, Washington, California, Vermont, and Montana. Physician-assisted suicide should be legal in all 50 states. There are too many people throughout the world suffering from cancer, Alzheimer's, and other conditions, and those affected should have the choice to end their sorrow. Physicians employed under the states that have legalized physician-assisted suicide, or aid in dying, AID, which the term is recommended by the American Public Health Association, need to be safe and accurate, need to know the best way to handle the situation when a patient has an inquiry about aid in dying. There is a criteria for physicians to help them guide the process, including discussion of the patient's reasons for requesting aid, evaluation of the patient's decisional capacity, and assessment of the patient's understanding of palliative measures that might be used instead of or concurrent with aid. When a patient requests for aid, one major criteria is that their condition must be incurable, which will result in death within a relatively short amount of time. Physicians also must consider their mental and physical health, finances, and peer support that may or may not be persuading their choice. The objective behind the criteria is to deter any premature action by the patient, to establish whether a request reflects decisional capacity and freedom from external pressure, and to ensure that the patient is considering alternatives to aid. Aid must reflect a considered and voluntary choice by the patient. Once a patient and physician have come to the conclusion that aid in dying is the best option, the physician must inform and make sure the patient understands the procedure in its entirety. The patient must wait 15 days for the prescription after the request in Oregon, Washington, and Vermont. California and Montana don't have a specific amount of time they have to wait, but the physician must be absolutely certain that the request is, without a doubt, the best choice for the patient. Once the physician has granted the patient's wish and is ready to prescribe the medication, the physician has to find a pharmacist who is willing to participate, since they are allowed to opt out from preparing the medication. Once the medication has been prepared, patients are required to self-administer the medication and must do so in a private area. Not every patient who has possessed the medication ends up taking it, but it has been noted that aid patients realize an improvement in their quality of life from the sense of control that comes with mere receipt, not ingestion, of the prescription. A patient can choose another alternative to end their life, and they can choose to do so by willingly refusing to eat or drink anything. since physician-assisted suicide isn't accessible for many terminally ill patients. Declining food and water has been suggested by medical professionals. This method is legal throughout all 50 states and does not require involvement of a doctor. The New England Journal of Medicine did a study by mailing a questionnaire to all Oregon-residing nurses who work for hospice programs. In the questionnaire, the following definition was used. Voluntary refusal of food and fluids describes an action by a patient who voluntarily and deliberately stops all food and fluids with the primary intention of hastening death. This does not include stopping food and fluids for other reasons such as loss of appetite or inability to eat or drink because of a disease. There are few reports of patients who made this choice, but the purpose was to analyze the results of voluntary refusal of food and fluids to accelerate death used as an alternative to physician-assisted suicide. The main factors that influenced the patients to accelerate death in this study was to control the circumstances of death, viewing life as pointless, having a low quality of life, and the readiness and desire to die at home. In this study, intolerable pain did not appear to be an important reason for their choice. Based off of the questionnaires that were returned, 126 nurses reported a patient who chose this method. These nurses reported 16 patients later resumed eating and drinking, 8 of the outcomes were unknown, and 102 were successful at accelerating their death. 3 of those nurses indicated that they believed it was unethical for a patient to end their life using this method. As a nurse myself, I would ultimately respect a patient's decision, no matter the situation, but I agree with those 3 nurses. Going a few hours without any food or water can sometimes be agonizing. Imagine going 7 to 15 days without, which was the amount of time it took someone to pass away. Even though it was stated that most deaths from voluntary refusal of food and fluids were peaceful, with little suffering, although 8% of patients were thought to have had a relatively poor quality of death, this method appears barbaric. The patients who chose to restrict food and fluids over physician-assisted suicide appeared to have a neurological disease which would make them unable to administer the lethal medication themselves, which is a requirement for the Death and Dignity Act. The preference for which method a patient may choose can depend on access to a doctor, importance to control the situation, beliefs, and family views. Each patient has their own reasons for which method they choose, but those choosing physician-assisted suicide place more emphasis on controlling the time and manner of death. Patients who choose to accelerate their death can choose whichever method is more applicable to their situation. It was concluded in this study that hospice care patients who chose to restrict food and fluids usually die a good death. Cancer is a continually growing epidemic in today's society, and those affected by this disease with a terminal prognosis are considering physician-assisted suicide as one of their options. According to the New England Journal of Medicine, participants in Washington made up about 78% of the Death with Dignity program and 81% in Oregon. In regards to cancer patients, some of the most common motives were due to the loss of autonomy, loss of self-worth, being incapable of engaging in activities, wanting control of an uncertain situation, and current or future unbearable pain. Everyone involved in the program are aware of their options, and the families of the patients who decided to move forward with their plans to accelerate their death describe the pain as peaceful. The Death and Dignity program has been well respected and accepted by everyone involved. Wilkinson stated, "How can it be lawful to allow a patient to die slowly, though painlessly, over a period of weeks from lack of food, but unlawful to produce him immediate death by a lethal injection, thereby saving his family from yet another ordeal to add to the tragedy that has already struck him? I find it difficult to find a moral answer to that question, but is undoubtedly the law, and nothing I have said casts doubt on the proposition that the doing of a positive act with the intention of ending life is and remains murder. Anyone can make a difference by joining the Death with Dignity movement. The Death with Dignity National Center is a non-profit organization advocating to the people, while the Death with Dignity Political Fund is a non-profit organization that is working on drafting Death with Dignity law, campaigning, lobbying, and advocating for legislation for the 46 remaining states. More information is found at www.deathwithdignity.org/takeaction. Physician-assisted suicide is a sensitive and controversial topic, but those who are suffering from a terminal disease want the federal law changed. Let the people choose what is best for themselves. As stated by R.D. Working, an advocate of assisted suicide, making someone die in a way that others approve, but he believes a horrifying contradiction of his life, is a devastating, odious form of tyranny.